Hello everybody, today we are going to have the round of examination of varicose veins under the conceptual surgery concept, and I'm Dr. Jignesh Gandhi, unit head at KM Hospital Mumbai, and with me is my colleague Dr. Samir Deolekar, who is an associate professor and senior consultant at the same KM Hospital, and we are going to have a module on where we are going to show you how to do clinical examination of a varicose veins. So Dr. Samir, what are the prerequisites before you actually start? How do you go about when you see a patient of varicose veins? And it's always a good idea to also see for certain visual cues, because a lot of times these patients would be having some crepe bandages along with them, yes, or they may be carrying some mobility aids like some kind of a walker. So this probably would give an indirect parameter that this patient has got some crippling problems. Yes. So it's always good idea for the students to look around, see what all the patient has come in what kind of aids he has along with that, because that tells you. And even sometimes they have a very bulky dressing on the lower limb, which tells you upfront that the patient has got a varicose veins.
Yes, it indirectly gives us a hint that what kind of discomfort this particular pathology is going to cause and has caused on this particular patient. If there is a deformity, if there is an ulcer, definitely patient will be in a lot of discomfort, and indirectly it gives us a hint that we are not dealing with a primary varicosity, but we are dealing with a complicated varicosity.
Correct. So on the general examination, what should be the exposure of the lower limb?
So Dr. Jignesh, before we move ahead with examination of varicose vein, can you just give an insight about the course of varicose vein? What are the different kind of perforators we get and where exactly they are located?
So if you see starting from the top, it's always a good idea to identify the pubic tubercle. And once you have identified that 4 centimeters lateral and below, you will have the great saphenous opening. That's where you will have the joining of the saphenous vein along with the femoral vein in this area. And then you have the entire course as it is marked here. Usually the perforators from below are at the level of 5, 10 and 15 centimeters. These are the constant perforators. The next perforator which you have is below the knee, and then you have one perforator which is above the knee. And so these are the ones which are constant, but otherwise you have about 50 to 60 perforators which are there in the lower limb. And then once you see on the opposite side, it's always a good idea also to see the patient in lying down. And when we make the patient stand, that you see that the course of the short saphenous veins also. Now the important point to understand is that the saphenopopliteal junction of the short saphenous usually is not very constant. Yeah. It can vary from patient to patient. Sometimes it can be here, it can be here, it can be here. So intraoperatively, when you are using in a ultrasound or a Doppler, it becomes very easy for you to identify that.
Right.
Okay.
And we usually club together all this above or the ankle perforators, what we see or what we are marked here. They are basically clubbed under one group, that are ankle perforators. Correct. So be it 5 centimeter, 10 centimeter, 15 centimeter, as far as the clinical implications are concerned, as far as the management are concerned, it doesn't make any difference. So they are grouped under ankle perforators.
And what are the skin changes? Usually 2 types which we see in patients with varicose vein.
In a primary varicosity, we obviously don't get any kind of skin changes, but if it's a prolonged course, if this is a kind of complicated varicosity what we are looking for, then definitely expect some kind of discoloration, blackening. That is one, that is very important. Secondly, sometimes what happens is because of excessive pain, patient tends to walk on the toe. So this chronic walking on this kind of position usually gives rise to what is called as a horseshoe shaped deformity. That means there is a lipodermatosclerosis, because of which there is a thickening of the tissues around the ankle joint, and patient tends to walk on toes. So typically we have what we call as a horseshoe shaped kind of deformity.
And it's also important for students to understand that this is a gaiters area. So if you see the history, it was there was a covering which used to be given to the military guards in the good old days, and it was a leather cover which used to cover up this part of the ankle because they used to fight in the cold weathers.
Right.
And that's where the word gaiter comes from that revolution which the armies used to wear. And you also have a bishop's gaiter, which is also one of the ways it is described, because which typically covers up this part with like a scarf. So initially it started with the leather, and now it has gone to a cotton material. But that's important because sometimes you are asked in the exam about what is the gaiter area. So having said that, and about the skin changes, if you have an ulcer, then how does the student proceed?
I would definitely suggest not to proceed directly on ulcer, because these are painful ulcers. So first examine the varicosity as such as a proper thing. That means just locate the site of perforator, see whether the patient is having a deep vein thrombosis, and then before you finish off your examination, then you talk about the ulcer, because then whether it's a clean ulcer, whether it's a bad ulcer with a slough, the management changes. So don't directly jump on the ulcer.
So it's very important to understand this point, that once you have a varicose veins, complete the examination of the varicose veins, and then you open up the ulcer and examine that part. So that part can be separately mentioned as a complete ulcer examination, right?
Yes, and
now,
here you have to be careful because these are not like a regular ulcer. These are very painful ulcers. So definitely when you examine, you have to be very, very careful about that.
Correct. Now, talking about the test which we perform, roughly what is the principle behind those tests? So what are we looking at?
As far as the varicosity is concerned, the examination of varicosity veins are concerned, two important principles has to be followed. First, we have to know which varicose or which system is affected, whether it is a long saphenous system or whether it is a short saphenous system. So in case we happen to find out it is a long saphenous system, the second principle of our examination is to cite or exactly locate the site of perforator incompetence. And once we have found out that, then depending upon the kind of perforator incompetence what you have got, the last thing what remains is whether the patient is having a deep vein thrombosis or no. So in case I want to sum up, I will sum up the examination to three parts. First is to examine the varicosity, long saphenous vein or a short saphenous vein. Second thing is to locate the site of perforator incompetence, and third thing is to know whether patient is having a deep vein thrombosis or no.
Absolutely. So I think it's a very nicely compromised thing that if you follow these principles, identify the system, long saphenous versus short saphenous. The second principle is to know which perforators are incompetent depending on the test which we are going to show. And finally, once you have done that, whether the patient has got clinically evidence of DVT or no. We know that today the gold standard is Doppler, but clinically there are some tests which we will talking about which can give you a rough idea whether the patient has got deep vein thrombosis
and it
or
significantly changes your line of management. Moment you come to know that there is a deep vein thrombosis, we know the treatment is going to be conservative. Moment there is no deep vein thrombosis, everything is fine, we can opt for surgery.
Absolutely. So it's a very, very important finding which we should look at. So now we will move on to the next module which we will be talking about the varicose veins test.
Right.
So, Dr. Samir, how do you go about performing the test? Can you just elaborate on which test we are going to perform first?
Okay. So, when we are talking about the different tests, what is performed for the varicosity, the first test which comes in line is a Brodie-Trendelenburg test. That is nothing but just to see the patency of the saphenofemoral incompetence. So, in that case, what we do is make the patient supine, elevate his leg to around 30 degree, empty the vein. So, the vein is totally collapsed. Okay, empty the vein, see that you are milking the vein right up to the saphenofemoral junction. The entire segment of the long saphenous vein has to be emptied. So, after you had emptied the vein, you tie a tourniquet. Now, again here you have got two options. You can either use a finger, but sometimes what happens if the patient is obese patient, to locate the saphenofemoral junction becomes very difficult. So, instead of applying a finger, you can as well use a tourniquet. So, that tourniquet, see that you are applying it below the saphenofemoral junction.
So, important is that just below the saphenofemoral junction.
So, instead of using a finger, best thing is to use a tourniquet. In fact, that's why it's called the Tourniquette test.
And once you have applied that, and you have applied, then you will make the patient.
So, here I had already emptied the vein, I had applied a tourniquet.
Yes.
Now, there are two parts in this particular test. In first part, what we do is we apply a tourniquet, make the patient stand up immediately. Okay. We see one important thing here. Moment the patient stands up, we see whether the veins above the tourniquet is filling rapidly or no. So, in case we happen to see that the vein above the tourniquet is filling rapidly, that means the saphenofemoral junction is incompetent. Okay. So, we call that as positive test, or we interpret that as a positive test.
And there is also a possibility that if one of the perforators there are incompetent and the patient is standing.
The second part is to remove the tourniquet and see whether it fills rapidly from above or rapidly from below. So, in case it fills rapidly from below, that means even your saphenofemoral or apart from saphenofemoral, even your below leg perforators or the above knee perforators, below knee perforators are incompetent. That we interpret that as a negative positive test.
Okay. So, Dr. Samir, the principles of the varicose veins test is the first is the Brodie-Trendelenburg test, where the principle behind that test is to identify what is happening to the saphenofemoral junction, whether that is incompetence or competent.
Right.
So, in that test, the first thing is that we are going to make the veins empty by raising it to about 30 to 45 degree. Once you have done that, that means you have emptied out the entire vein. And as you rightly mentioned, you know that we have to see that we milk out everything and then put it back here. Once you have done that and we have identified the SF junction in the initial inspection, we put in a tourniquet just below that, because what that will do is that will block the blood which is coming from the SF if it is incompetent and try to fill up the vein. Having done this, the next part of that test is that you have emptied out, you have put in a tourniquet, make the patient stand. So, when you make the patient stand with the tourniquet in place, if there is a rapid filling from below, okay, that means that the perforators are incompetent, or you may not see any filling at all, that means your SF is incompetence because the blood was leaking from there, which we have stopped, and that's the reason this is not filling up. The second part of the test is that we do the same maneuver now, and now what we will do is that since we have identified it, we will release this tourniquet in the second part, and with the release of the tourniquet, what will happen is that there will be a further gush which will be filling it from above downwards.
So you mean to say there are two parts for this
There
test?
are two parts. So there is a second part where it will tell there is a rapid gush, so the SF is incompetence. The whole idea of this test is to identify whether the saphenofemoral junction is incompetent or no.
Okay. Are there any other tests which will locate the exact site of perforator apart from SF incompetence?
So you will also be doing the multiple tourniquet test. The whole idea again remains the same, that at every mark points which we have done, these are the constant perforators, you know, so you will be marking at 5, 10 and 15 centimeters, and you will be putting tourniquets below that at each level. Okay, and then again the same thing, that first make the patient lie down, empty out all the veins. The first will be 5, 10 and 15, so you will be probably putting it up at 4 centimeters, 8 centimeters and 13 centimeters just below that. Then you have identified the below knee perforator, you will be putting in a tourniquet below that. Above that tourniquet, you will be putting just below that, and again one more here. And then when you make the patient stand, you will be releasing the tourniquets. So you start releasing it from below upwards, and as and when you will keep on releasing the tourniquets, those section of the veins through the perforating channels will start filling up, and it will tell us at which level you have incompetence. So maybe you release the first 3 tourniquets, you may not find anything in the filling, but as you release this one, the one which is just below that, you release it and you find that this section of the vein is filling up. So whichever section is filling up, the perforator above that is incompetent. Remember that. So if you release this, you find this is filling up. When you release this one, you will find that this segment is filling up. So wherever you in the multiple tourniquet test, you release that particular tourniquet, below that section, whatever are the perforators, they are all incompetent because the blood starts coming up from there. This is how you will be performing.
So here you mean to say you are dividing the whole segment of the vein into multiple small segments, and ideally locating the site of exact perforator incompetence.
Correct. So you may have all of them incompetent, or you may have segments or individual perforator which may be incompetent.
Dr. Jignesh,